Good afternoon, and thanks very much for the invite along this afternoon. Just going to try and give you a wee bit of information about the services we provide for people in Glasgow with ARBD and some information about the causes and impacts of alcohol. The gist of the slide that we have here is, I'm trying to list some of the ways that alcohol-related brain damage comes about. Alcohol in itself is a toxic substance, impacts on the brain. People, when they're drinking, going through cycles of withdrawal and intoxication, it's doing damage to a very sensitive organ. But probably the key player is alcohol. Although it contains calories which suppress appetite, the calories are empty and they don't convert into energy. So we kind of started the thinking about thiamine because thiamine, vitamin B1 is important for today. We don't naturally have thiamine present in our body, so if we're not eating, then we're going to run out of thiamine basically, and we're only going to get it from the food we eat. And part of the message from today is that vitamin deficiencies and continued drinking do cause problems with brain structure and with function. So just a kind of a whistle-stop tour. And as I described, heavy drinkers, their thiamine intake is reduced because the calories they're taking in from alcohol. Your gut, your pancreas, your bowel, etc., they're involved in the processing of vitamins, and alcohol hammers those organs as well and makes them less able to absorb vitamins, even such vitamins as are around. Alcohol uses any thiamine that may be in the system to metabolize. So the key about this condition is alcohol keeps the drinker thiamine deficient and causes them to be thiamine deficient. Continued risk of thiamine deficiency or if you continue in thiamine deficiency for any length of time, it places you at risk of what's called Wernicke's encephalopathy, which is a very serious condition which can result in someone drifting into coma and death. So I'll speak a bit more about Wernicke's in a few slides. This is, this slide here kind of gives some idea of the damage that alcohol and associated thiamine deficiency can do to the brain. The healthy control brain on the left, you can kind of see the sulci and gyri of the brain are fairly well sort of defined there in the image, whereas on the right hand side, the alcohol damaged brain is, it's much less defined. But key to what we're kind of talking about today is that the area in the centre of the brain, the ventricles, in the healthy control is quite a small space with the white fluid around it, cerebrospinal fluid, where the alcohol damaged brain, the shrinkage to the brain ultimately causes the ventricles to dilate, and that's exactly what you're seeing in those slides. Now, as we all get older, we do experience atrophy to the brain. However, it's worth saying that both these individuals are in their 40s, so you're looking at alcohol and thiamine deficiency rapidly aging the brain. And some of the impact it does to the brain itself, some of the areas damaged, the cerebrum and the limbic system, the cerebellum, and neurotransmitter systems. What we've done here in this slide is list some of the difficulties that are caused, reduced connectivity, atrophy and shrinkage. These areas are responsible for a range of functions, as you can see here: planning, problem solving, memory, emotion. If you think about drinkers, and this starts to occur long before any major neurological signs, if you think that drinkers are starting to experience these difficulties, it's worth having a think about what's actually going on for the drinking population prior to them receiving a diagnosis of alcohol-related brain damage. So in 1991, this study, Tuck and Jackson, they looked at male drinkers who didn't have any obvious neurological signs and did a lot of testing with them and noticed that they did have some cognitive difficulties. They suggested that maybe 10 years before any diagnosis was warranted that these problems begin to show. And in fact, what they were, some people would highlight is that social drinkers, people who drink heavily, socially, can experience some cognitive difficulties as well. So one of the key kind of thinking or thoughts were that there's less research on sort of healthy and alcohol-dependent patients who are now abstinent. How have they been affected? They might not merit a full diagnosis, but what has happened for them and how have they been impacted? Some of we looked at some of the areas of the brain and some of the functions impacted, but if we look here at executive controls we all use basically every day. If you think about behaviour change, dieting, giving up smoking, these are the skills that we use, and I would say that these are the skills that we use to stop drinking, to change behaviour. They allow people the capacity to reflect, what isn't working, developing plans, setting goals, and importantly, learning from mistakes. So if these problems are building up way before any neurological signs are starting to show, as they are, then we're looking at a group of people who actually are probably find it very difficult to change their drinking behaviour. And there's a real message for services in this, and sometimes I feel that you almost get worn out trying to say to people, stop talking about people making a choice to drink. Some people do choose to drink, but you can't automatically assume that everybody is making an informed choice or is able to change their behaviour. Mental Welfare Commission kind of highlighted in 2006, you don't really know exactly when the diagnosis would be merited. Bates and colleagues, 50 to 80% of individuals who have alcohol use disorders experience mild to severe neurocognitive impairment. Jenny Svanberg, a former colleague of ours, she was highlighting that many treatment programs are looking for people to be able to engage, to use their executive control, and a lot of the people, these guys are the guys who are being referred to them, can't do that, and they won't attend and they won't come to the office, so they get labelled as being poorly motivated, pre-contemplated, or people who don't want to engage. And actually, if you go and see them at home, you'd be surprised how many of them actually do want to engage. And more importantly, if you go and see them at home and don't talk to them about alcohol, they do want to have a conversation with you. Some of the diagnostic terms that are around are alcohol-related dementia. The purpose of today is probably not to break into every one of those and what they mean. Most commonly what we talk about is alcohol-related brain damage in the context of Wernicke's encephalopathy, the acute phase which is kind of set up by thiamine deficiency, and Korsakoff's syndrome, which is the more profound end of the kind of condition. Both discovered completely separately, but they are kind of separate ends of the same condition. Some people say alcohol-related brain injury, and debate rages on that. The reason you have to be very careful with diagnostic terms is different people have different attributions for different terms. Why we're so picky is we need to know if alcohol and thiamine deficiency are the main cause, because if they are, then alcohol-related brain damage is not a progressive condition if someone stops drinking. Hence, we do a lot of work in differential diagnosis. These are the memory problems that people experience in Korsakoff's, short-term memory. Introduce yourself, someone can repeat your name back, but after a few minutes they often can't remember your name. They may have problems with memories. They may tell you a whole load of memories which are accurate, but the time tags are all over the place, the chronology is poor in it. What you notice commonly with people is they'll remember their earlier years, their childhood, their teenage years and their 20s, but as they go on, and probably as their drinking increased over the years, their memory becomes vaguer. You often see something called confabulation, which is, it's what it is a tendency basically to fill in gaps in missing memory, as I've kind of written there. Somebody might tell you, you ask somebody what they did last night, they might tell you quite a fantastic story, or they might tell you something that's quite subtle. Basically, in a difficult situation where you probably know that you should know what you did last night, your brain will compensate and try and make sense of the situation. So they're not, as people sometimes say, lying to us or not trying to deceive us. In 2006 then, the Glasgow sort of team came together, prompted by a lot of things, I think, a lot of research, Mental Welfare Commission, the Scottish Executive, the Fuller Life Report through Stirling University. And, they recommended Stirling Uni basically that, needed a multidisciplinary team to address a range of need. And I'd have to say probably, I would say they were accurate in that. This is the makeup of our team. Every discipline is absolutely essential, as I say, to meet the kind of range of needs. We have vacancies at the moment in some of these posts, and we do function, without some of the disciplines, other than the team leader, obviously, who's essential, that being me. But at different points, we can muddle through a wee bit. However, these are the disciplines that would serve us best, I would say. We try to be as accessible as we can, to operate an open referral system. to talk to people, not to pass referrals on. You know, it's good if somebody's had a provisional diagnosis, but we would look at that anyway and see if, you know, and see to make sure, try and make sure the person is able to participate in rehab. We can arrange Teams discussions with people. We do sometimes, you know, and the key around that is not saying, you know, what some people do is the GP will write to them, and, or, you know, to perhaps a mental health team, and they'll say, oh, it's more suitable for the ARBD team, but they haven't spoken to you. And we're talking about people here, not bits of paper. So, you know, we try and be as accessible as we can. We have a process, as I've kind of written here, of assessment, and this is that, you know, speak to everybody, gather as much information as you can. Are we sure alcohol and thiamine deficiency is the problem? Put together an assessment to discuss with the team and to discuss with the psychologist and the psychiatrist, and try and look at all the brain imaging available. Cognitive screens, occupational therapy assessments, you know, essential, and I'm reflecting as well in the earlier discussion about, you know, benefits and accessibility, or access to benefits, how essential those assessments can be. A neuropsychological assessment, this would be the gold standard for our team in terms of, you know, differential diagnosis and also developing a rehab plan. So that's the kind of probably the key assessments. Quite lucky in Glasgow, we're quite well served, but we don't work alone. We work with other organisations. We work with people at home, but we work with people, you know, for example, who are in care homes. But a lot of the work we're doing just now is with Penumbra, the Wheatley Group, and SAMH. There are 3 different services there, each of which is pitched at a different level of kind of intensity of support. So we're working through now this kind of idea that people can go through staged rehab, increased graded exposure to independence, and it started to work. It was difficult at first, trying to get everyone to think the same way, but it works. And what we're looking to try and do is support this idea of reducing harm and stabilising the situation, and trying to support people who are drinking now and who need, you know, more help and support, to try and bring them in to sort of neuro rehab, and then ultimately to try and move people, you know, back into the community and into their own homes. And I'll hand over to Kate now, who'll give you some information about interventions.
Hi everyone, I'm just going to talk very briefly about some of the work that we do day to day to people in recovery with ARBD. So most of our referrals come from acute hospitals. When we first get a referral, we want to gather as much information as we can about the person, looking at their health and social work records, speaking to their family and loved ones, finding out what it is that brought them into hospital, how are they managing at home, what their alcohol history is like, because at this stage, people are very often very confused. They're presenting with reduced insight, memory difficulties, and confabulation, like Grant mentioned earlier. They're undergoing treatment for a range of physical health issues and on alcohol detox medications. So we really want to know as much as we can about that person, to know what's going on for them, and are able to measure their understanding of their situation as well when we meet them, because their self-report might not be very accurate at that stage. Particularly where a person's been deemed to lack capacity to make informed decisions surrounding things like alcohol use and their care needs. There can be a lot of really complex discharge planning meetings, adults with incapacity case conferences. So a lot of different professionals visiting, psychiatrists, mental health officers, social workers, advocacy workers, really overwhelming and a lot to remember. So we want to support people to remember those discussions, take part in them, know what the plan is going forwards, and work collaboratively towards a rehab placement. So we'll introduce a communication book, put a picture of one on the slide, just a notepad for them to record all of that information. I'll put my name in the book, the role, the team that we're from, how can they get in touch with us, and answer any questions that they might have about the plan going forwards, so that when we leave the ward, they've still got all of that information to go over in their own time. When I go back to the ward at a later date, they might not necessarily recognise me, but if I say, oh, I'm Kate from the ARBD team, we met last week, then they can say, oh, your name's in my book, and we can sit down, read what we spoke about last week, and then pick up where we left off. And that's really the start of developing a compensatory system as well. So I think Pamela mentioned earlier how important lists were to her in her recovery journey, but we encourage everybody that we're working with to develop a compensatory system to help manage those difficulties with short-term memory, planning and organising. Things like having a memory clock or an alarm on your phone to remember to take your medication, having a whiteboard for your appointments and activities, keeping it in a visible place where they're going to see it throughout the day, building it into their structure and their environment, so it becomes second nature for them to look at it and update it. Somebody we're working with kindly gave us a picture of their daily planner to use as an example. So he required a really high level of verbal prompting to go through the sequence in the morning when he first moved to the service, and now he goes through it by himself every day, ticking it off as he goes. That's his handwriting as well. He always says that if it's in my handwriting, I'm going to believe it. So we really want to promote that sense of ownership of the system. It's their whiteboard, it's not the staff whiteboard, otherwise they won't use it when we're not there. Things like having visual prompts around the flat. Have you remembered to turn the cooker off? Have you got your phone and your keys before you leave the house? You know, have you got a calendar so you know what year it is? And they're all just really basic strategies, but we find that it's the basics done well that really make the difference for people in managing their day-to-day, their lives and their activities. For structure and motivation, one of the features of alcohol-related brain damage can be that reduced motivation levels, and that's something we hear from families and carers can be quite frustrating at times. There can be a misconception that the person is being lazy, or they require a really high level of prompting, maybe verbal prompting to get up in the morning to do like daily tasks. Maybe if they're invited to go out the house, they just want to sit inside and watch television instead. So it's really important for our team to support families and carers and the person to understand how alcohol has affected their brain, that it's a feature of the condition. One of the main ways we support people is to have a person-centered care plan and individual recovery goals, finding out what it is that they're excited and what they want to be doing with their time. You know, if we think about addiction as a process of becoming disconnected from the roles, the relationships, the activities that you enjoy doing, then your recovery is part of reconnecting with them. What do you want to be doing with your time? And that can be a really difficult question sometimes for people to answer if you've been drinking every day for 10, 20, 30 or more years. So we're there to support them to explore that, looking at activities and interest questionnaires, going new places, trying new things, sitting down at the beginning of each week and planning your week out, saying, you know, what do you want to be doing with your time? Every morning going into their room saying, what's on your whiteboard today? What's the first step in getting that task done? When somebody does do something, reflecting on it and seeing what went well, what was more difficult. You know, do you need more support to get this task done? Maybe you need less, you're going to do it by yourself next time. Linking back those small daily tasks to the person's overall recovery goals. So it might be that they want to go volunteering in the future, so they're going to practice the bus route with you every day so that they can travel there independently. And when somebody does do something, it's recognizing that progress, celebrating the achievements that they've made, and building that sense of self-confidence and self-efficacy, because sometimes, well, what we hear very often from people is that they don't remember being in hospital. So if they don't remember being in hospital, then they might not remember just how far they've come in such a short period of time. And that was something that we kept hearing time and time again from people, is that they don't remember being in hospital. So we were thinking as a team, if you get told you've got alcohol-related brain damage in hospital, you get told information about ARBD, but you just don't remember it, how is that going to impact on your recovery in the longer term? And we started having that discussion with service users and came up with the idea with developing an ARBD recovery passport. We were very inspired by Professor Ken Wilson's rehab guide, in which he describes developing a jointly developed document with the person and their key worker that describes the impact that alcohol's had on their cognition and their physical health, that they can then read in their own time and rehearse their journey and the impact that alcohol's had on them, helping to orientate them to their new circumstances and understand exactly why they're in treatment. As Grant said earlier about the assessment process, you'll see psychiatry, psychology, occupational therapy. We were thinking about how the outcomes of those assessments are communicated and recorded for clients and their families. So the aim of the passport is to have this sort of one-stop shop for everything that collates all of this information, something that person can keep, that's going to empower them to communicate their support goals, their needs, their wishes, what they want from their support going forwards, particularly during transition periods in the ARBD pathway. So if somebody's moving from, say, Penumbra to Fullerton, how do we communicate everything we've learned from that 13-week placement and give that to the new staff as well? So the passport includes their recovery story, relapse prevention plans, coping skills, information on ARBD, nutrition and thiamine. There's things like Is there any legislation involved in my care? So who's my advocacy worker? How do I contact them? Who's my social worker? Do I have a guardian? And the passport is currently with governance. We've been trialling it with service users, gathering feedback on how it's actually working with people, and we're looking to get some comments from families and staff that are using the passport as well, and then hopefully we'll be able to share some more of that with you in the future. This is just some of the insights that we've gathered from service users during consultation sessions for the passport. So the gentleman whose daily planner we saw earlier had said to us, I can forget small things, but they mean the world to me. If it's written down, I can go back to it if I forget. I forget that I don't remember things. Again, I don't remember being in hospital. And then somebody else was saying about how when I was drinking, I thought it was normal to forget what you'd done, but then I started to forget when I hadn't been drinking, and I didn't know about ARBD team until, we pop up. And I think that's the thing. There isn't really a public health messaging about how alcohol can affect our brain. We all know how it can affect our liver, but, nobody's really heard about alcohol-related brain damage a lot of the time. So just some of the sort of key messages of supporting rehab is doing the basics well, using compensatory systems, promoting a with, not for, the person principle. We want them to be, we've gone too far, using it when we're not there, having a consistent and person-centered approach to recovery, using the right intervention at the right time. We don't want people to become overwhelmed, but we want to keep supporting them to be moving forward in their recovery. Having a whole systems approach to care with staff and family, involving everybody in the network to work together towards shared recovery goals, identifying what works well for the person, what's meaningful to them, repetition to consolidate and to support that consolidation of new information and learning, the value of abstinence-based environments in early recovery, like places like Penumbra and Fullerton, because abstinence is essential to recovery with ARBD, and where people are deemed to lack capacity to make decisions around alcohol, the supportive use of legislation when necessary, always using the least restrictive option, but to keep them safe and to give them that chance to recover and to have significant recoveries can and do happen with ARBD. And then lots of other information that I won't go through. But thank you very much. I'm not sure if we've got time for questions, but we always like to hear from people if you want to get in touch with us.